So Melissa, respiratory therapist, flight paramedic, and you've been doing this how long now?
Well, I became an EMT in 1998, right out of high school when I was 18.
Yeah.
And I did that until 2004 when I went to respiratory school. So I've been an RT since 2004. And then in 2011, I went to paramedic school.
Okay. And why the transition? Why the switch?
You know, for me, I got a taste of transport medicine. And unfortunately, just the way things are kind of falling with adult RTs, that they've kind of been phased out of transport teams all over. So I was on an adult transport team. I wanted to stay that way. And the only way for me to stay was to go to paramedic school. So that's what I decided to do.
Oh, okay. That's interesting because, like I said, we've been working together for 3 years, and I always kind of wondered why that transition. But that's pretty cool. So it was just a matter of keeping yourself in the mix, kind of doing what you like to do.
Yeah, you know, I kind of just got the addiction of doing transport and just didn't want to go back to just being in the hospital all the time. So I decided to make that jump and kind of go back to my roots in the beginning from when I used to be an EMT a long time ago.
And you didn't want to just focus on pediatrics, of course.
No, I really like where I am now that, you know, we take care of kids like 3 days to 100 years old. So
right.
I like not knowing what I'm walking into every day. Sure,
of course. So you identified a need in the industry, and that's what we're going to really talk about primarily is pre-hospital critical care ventilator management, right? Mm-hmm. And you've developed this course Beyond the BVM, which you and I have talked about a little bit, and I think it's spectacular. I've told you that so many people that actually come on and join the group are asking for ventilator management training. So what did that you really identified that made you want to pursue this? Like, what was the reason?
Well, you know, I've been kind of training my teammates for a really long time, especially when we were making that transition to get rid of adult RTs at the team I used to be on. So I pretty much oriented the entire paramedic side of that team before I left. And then when I started up again, I ended up becoming a resource just for some other team members and looking more and more and getting more questions from my paramedic teammates. I kind of realized there was a gap. That, you know, there's some big transport classes, but nobody focuses just on ventilation. It's always kind of part of it, but there's so much in that one class that I think it's really hard to master any of those things in the beginning. So I think that giving this subject its own time is important.
Sure, that's why they have respiratory therapists, right?
Yeah.
I mean, there's enough to it that it's important enough to have specialists at managing ventilators, right? Because that's primarily what you're asked to do.
Yep.
I think it's brilliant because I know that when I started, that was one of the things that was most intimidating to me. You know, lots of other things. You know, of course, it's a big transition from working in the back of an ambulance to working in critical care. But ventilator management was one of those things that I think. Clearly, based on what I've seen people asking, you know, about, it's one of those things that people feel least comfortable with across the spectrum, paramedics and nurses. So I think it's awesome. So I definitely want to kind of dive in and actually pick your brain a little bit and kind of really get to the meat of ventilator management as much as we can in a 1 hour show, and really kind of get some points out to the staff and to the listeners that they can really kind of apply to their practice. So I know when we practice, we kind of say all patients who are intubated need to be on the ventilator. So why is it so important that we're putting our patients on a ventilator versus just bagging them? We've done that for years.
I think there's a couple different ways to hit that topic. The number one thing that comes up to me is that I'm more than just a person that can sit there and bag. Like, I have way more to contribute to this call than just that. So for me, if I can put them on the ventilator and I can move on and I can help my teammate titrate drips or start more IVs or whatever we need to do, I would rather be doing that. I don't want to be just tied to that one skill. I feel like I can do way more than that. Secondly, it's become kind of commonplace to just hand off bagging to who's ever on scene. Whereas I see it as the most skilled person should be the one bagging that patient. And then if you want to take that a step farther, if you have a very skilled practitioner that's very comfortable with the ventilator, now you're making that person that much better to have that ventilator with them. You're never distracted. The patient's getting exactly what you want them to get every single breath, the same consistent tidal volume. Just the vent is way smarter than us, and it's allowing us to kind of focus on other things within the call. So those are the two things that jump out to me right away about why I think it's important to put everybody on a vent.
Sure. Yeah, of course, we all know that it's so much harder than we are initially taught in paramedic school to bag a patient. Right now, there's so much focus on two-handed bag valve mask, which really requires two people, and really getting good mask seal. And we all know that that's much harder than they initially make it seem like. Yeah. Excuse me. I think
a plastic mannequin all the time.
Right. Yeah. And everybody's got that perfect symmetrical face, right? It's never an issue.
Yeah.
What about those times though when it's like a 5-minute transport? I mean, is it worth going through the process of putting somebody on a ventilator? Or even if you are doing like interfacility transports, you're moving somebody, from the scene to the aircraft or from the ER out to the aircraft. I mean, is it okay to use the bag during that period of time and just have the ventilator set up in the aircraft and start them on the vent there?
Yeah, I think that you have to play that call by call, basically. For me, just because I'm so comfortable with the vent, it's easier for me to go in, put them on when I'm in there, take a look at them really quick and make sure they're settled on there versus trying to troubleshoot that in the aircraft for the very first time. And so for me, it's not a big deal. I, throw the circuit on really quick on my way there or on my way walking in. I prefer even in the quick transports to have them on there. And I think you just have to be really comfortable with your fast setup. Make sure that you QC'd all your equipment that day and it's ready to go. So nothing's going to kind of surprise you when you throw that circuit on right away. And I think it's just one less thing that can kind of be pulled. I think you're more likely to pull an ET tube with a bag attached to it with someone's hand pulling it versus when you have an ET tube with your ventilator tubing attached. I tape the BVM underneath the circuit and then tape the circuit to their chest, and then that vent is down between their legs if possible, or else on top of their pelvis if it's not a trauma patient or something like that. So for me, I feel like it's a little bit more secure, and it's just part of my flow on a call to just kind of walk in and do that really quickly.
Oh, interesting. So rather than taking the BVM and stringing the mask along the supply tubing and throwing it underneath the head of the bed, you actually tape that to the patient's chest and use it as a support for the ET tube, so it's not pinching and getting pulled.
Yep, and that way it's not pulling on that ET tube, and you have a nice access if you need to use your inline suction and stuff like that. Your tube's not kinking, things like that. So
that's
you're not ramming it down into their carina and stuff like that. So hopefully it's a little more secure.
Yeah, there you go. Tips and tricks from a respiratory therapist, because it's happened to all of us, right? Something happens, the patient's not ventilating well, you do have to pull them off the bag, and now you're scrambling. Where the heck's the BVM? Where's the mask?
Yeah.
So having it right there.
Yeah, and I used to always find it laying on the floor, and and then I would have this internal battle going on about how I'm always talking about not taking them off the vent and trying to decrease their risk of pneumonia, and here I am picking up equipment off the floor of the aircraft. It's scrambling in that moment. So I try to always be 1 or 2 steps ahead of all the bad stuff that can normally happen.
Sure. No, I think that's good. Are there times when you think that it is appropriate to leave a patient on or to bag a patient and not put them on the ventilator?
Yes. So the one thing, the couple of things that come to mind, if you have like a really sick asthmatic, I think it might be behoove you to stay on, especially if you have an anesthesia bag, that's what I would use. Those are patients I like to feel, especially if I'm having trouble on the vent and I'm having trouble getting my settings right on the vent. I'd rather take them off, bag them with anesthesia bag, see what kind of pips I'm getting on there, and what kind of pip and peep I need to move their chest and really get their color to come back and those type of things. And that way I can titrate that vent so you don't have that big mismatch that happens when you take a patient off, you bag them, you get them where you want to be, you put them back on the vent, and they just dump. Most likely you're bagging a lot harder than you think you are, and that way you can really know what you're doing and then titrate the vent ahead of time, and when you put them back on, hopefully they're not going to have that big dump that they normally do.
Sure. Anesthesia bags versus self-inflating bags, right? I know that we work a lot with them. They're tricky, right? It's not something that you can just simply pick up. I mean, I remember when I first went into the OR, and that's essentially what they have hooked up to their ventilator, and you're squeezing it and there's no flow, and there's no chest rise. And I remember getting a little bit flustered, thinking like, the anesthesiologist is looking over my shoulder, and I'm supposed to be bagging this patient and doing everything I'm supposed to do, and I don't know their machine. So I remember the first time I had my hand on essentially a flow inflating bag, it was really weird for me.
Yeah, and for me, I think I cheated a little bit because I went straight out of respiratory school into a NICU PICU job. So those were, there were BVMs hanging off the side of core carts, but in every room was an anesthesia bag. So you just got used to bagging with them early on. That's how you're going to bag all your newborns when you're resuscitating them in the OR and things like that. So I just got used to it early on, but they are dependent on your skill level and your comfortability level. You can't just pick it up and kind of know what to be doing. You need to check it ahead of time. You need to know what kind of flow you need. So that's maybe a skill that if we're going to be doing critical care transport, we need to start talking about when we do our PICU clinicals, when we do our clinicals anywhere where we have access to pediatric patients, to be able to get our hands on those bags and bag those patients whenever we can.
Yeah. So you advocate it sounds like you're advocating for the use of flow inflating bags as much as possible.
Yes, as long as you have access to a gas source, because that's obviously what we need. And then as long as you feel like you're a skilled provider at that. That's just a step beyond your BVM, knowing, okay, so this is what kind of opening pressures you think you want, PIPs around 20, but if you really are having trouble with an asthmatic, you're probably going to be PIPs 30 and above on that thing. Are you comfortable going above 5 a PEEP on there? Because that's how you're probably going to have to move their chest sometimes. So just being comfortable with that bag is important. So if you're not, just getting good at your normal BVM, and then if you have access to that in your clinical setting, either up in your NICU, if you can rotate through there, any PICUs. Our team has access to some hospitals down in Denver that do just only NICU PICU. So we're lucky that we get access to those patients.
Yeah. What about flow inflating bags in the adult patient?
There's nothing that says you can't. The ones we carry for our babies can go up to 500 cc's, and we know that rarely are we even bagging adult men at 500, depending on how big they are. But for the most part, you can use those on everybody, and I wouldn't have a problem using on everybody. And in the OR, they're pretty much used on everybody. So it's as long as you have enough flow in that bag and you can move their chest and get the volume that you need, it shouldn't be an issue.
Okay, so you think that a pediatric flow inflating bag is sufficient for ventilating both adults and peds? Because I know that there's a big discussion in the MS world about the use of self-inflating bags and using pediatric size self-inflating bags for everyone.
Absolutely, yeah, because we know that one big double-handed squeeze of that adult size BVM, and you're either at 1,000 cc's or probably over.
Yeah.
And rarely do we ever see a male patient that needs more than 500 to 600.
Right.
So even by James DeCantu was doing a podcast where he just popped that bag in instead of pulling it all the way out.
I saw that.
Right in. So that's a good, clever way to do that, to just kind of keep yourself in check, that you're not over bagging someone, you're not giving too big a breath. But really pulling out a peds BVM is perfectly acceptable, and you can move as long as you can move their chest and get their sats where you need and they're pinking up, then I don't see a problem with it.
Yeah, I saw that podcast where they kind of popped in the one side of the 1,000 cc bag, and I thought, my goodness, that's brilliant. Like, how long have I been using a self-inflating bag and never thought about that? So I thought that was pretty cool.
Yeah, there's a pretty cool manometer on there that lets you see how high his PIPs are as well. It's a good one to watch. if you're thinking, oh, I'm like super good at bagging, you know, I can feel compliance, I can do all this, a nice, slow, easy push on that bag and you're at pips over 30.
Right.
So it's just kind of a good check for us as caregivers to kind of know, yeah, if you're bagging someone and you get them up, you were probably at like 30 over 5, 30 over 10. When you put them back on the vent and you're only getting pips of 20 with your, you know, 400 cc's of tidal volume, of course they're going to tank again because you've just taken away all that extra functional residual capacity you gave them back.
Right. Yeah. That's a great point. And you kind of alluded to it earlier about, you know, disconnecting a patient from the tube and not doing that and how that can have an effect on these patients. And I think, you know, you can speak to it better, but, you know, those patients who are PEEP dependent, you know, we're giving them high pressures in order to recruit those alveoli. And then we're popping them off the tube, you know, for whatever reason. Maybe we feel like we need to troubleshoot. We have high pressure alarms, which that might be an indication, right, to take them off the vent and make sure that they're not air trapping. But it could be that we're taking them off the tube. We're taking the bag off the tube, you know, because we feel like we want to protect their tube while we're transferring them, and now they crash because they've just de-recruited. Yeah. I know one of the habits that I've gotten into is taking like those clamps, the blue clamps off of the dialysis machines, and I'll clamp the tube to, you know, if they're PEEP dependent. What are your thoughts on that?
Yeah, and I think that is a great practice. I have been trying to get into the practice of clamping every tube every time I pop it off, whether I think they're PEEP dependent or not. And for me, it's taking a step beyond. It's trying to decrease the amount of germs that we're sharing with each other, with our patients. And, you know, they're already immunocompromised, most of those people. So if we can decrease the amount of whatever is in that aircraft, whether it's me or you that have a cold or something like that, I'm trying to take it a step further and say, hopefully I can decrease the amount of ventilator-acquired pneumonia that's out there, because that gets traced back to our field tubes a lot. So, and I know I'm guilty of it all the time, you know, setting all your stuff up on the floor of a weird house, you know, and just not sure where that tube has been before you slide that into their trachea. If we can try and keep our intubations a little cleaner, hopefully our morbidity and mortality of our patients will be a little bit better.
Yeah. I mean, I've heard people in the past say, well, you know, I'm going to do what I can, but I'm not really worried about it because most likely they're going to end up on antibiotics anyways. And, you know, I would say I've fallen guilty to that train of thought also, but we know that that's not always the case. And we know that ventilator-associated pneumonia can definitely lead to increased mortality rates.
Mm-hmm. Yeah, you know, and this is our chance to kind of Monday morning quarterback our calls. Just say, you know, if everything were perfect and I could set this call up perfectly, how would I do it? How would I set this up? What would I put underneath me? Where would I set my tube? That kind of thing. Am I not going to shove it in between the bed and the mattress like it's done so many times, you know? Yeah. So, that this is our chance to kind of say, if everything was perfect, how would I do this? And then try and do as much of that as we can on those calls. But I'm big on not de-recruiting our patients. It's going to take you not 2 or 3 breaths on that BVM. It's going to take 5 minutes to re-recruit and for that patient to build up that functional residual capacity. And, you know, and there's some debate about whether there truly is intrinsic PEEP or if it's just leftover volume in there. You can argue about that all you want. There's something in there. And when you put a tube down their throat and then leave that tube open, it's all going to leave. It's going from a negative high pressure to low pressure. And it's just what's going to happen. Your diaphragm's going to relax, push all that up, and then you lose everything. And then now your alveoli and your surfactant are all just rubbing around in there together. And that next opening breath is just kind of going to shred everything. So
interesting.
If we can just decrease that from happening, by clamping our tubes, then that's a practice we should all get into. Interesting.
So irregardless of whether or not they're you know, COPD or asthmatic patient, anybody who's PEEP dependent, you're saying that without the ET tube there, we're still able to retain some of that volume and keep our alveoli open, but with that tube in place, it's gone. And so everybody we should be considering consider a PEEP dependent type patient.
Right. They never fully exhale everything in their lungs. So theoretically, when you put that tube in there and stent their airways open, that is going to go from that high pressure to low pressure, and it's going to just kind of escape out of there. So theoretically, we need to help keep that in there. We need to decrease the amount of germs moving in and out of that tube anytime we can. So I'm trying to get into the habit of clamping every single tube just so that I don't forget on those really, really super important ones.
Interesting. I think that's a great point. All right. Well, I want to talk about specifically like some ventilator type stuff. So a lot of people in the group who are new to ventilator management. So we're going to kind of start at the beginning a little bit, and we'll see how far we get through. And maybe I can have you back for a follow-up show if we need to. But what is the number one thing that you see people who are just learning ventilator management, the number one mistake that you see people who are just learning ventilator management make?
I think that, whether it's me teaching them or somebody, I think that trying to learn from several people is a good thing to try. I think that sometimes maybe when I'm even explaining things, I understand them and I'm just not explaining them in a way that is hitting home for them. So I urge new people, yes, listen to me. Yes, every day when you walk in that door, take the piece of equipment that you're least comfortable with, and that should be what you pull out and work on every day. But I urge people to go onto YouTube. I mean, I know you've made videos about the Revell that we use. There's lots of videos out, whatever you're going to use, whatever vent you're going to use, and not just the manufacturer videos. You want to take people like us and people that have similar thought processes to us and have them explain it. Maybe they're coming up with really cool mnemonics. I'm seeing a lot of mnemonics around about how to see why your vent is high pressuring and things like that. So I think that just even if you're confused after that initial day where you're first learning about this, go home, go on the internet and look at some of these cool videos that different EMS agencies and flight agencies are making, because they're really kind of, and I don't want to say lowering the way they're speaking, they're just speaking on our level. And a lot of times when we see these vent reps doing it, some of them are RTs, some of them aren't. Some of them are purely equipment people. So, when you have a biomed person explaining something versus a paramedic explaining something, those are two very different things. And I have to say that my brain is not wired like a biomed person. There are many RTs. And I look up to them that are literally can just memorize a vent manual. I have several awesome friends who are so good at that. I am just not that person. I have to take something out and physically touch it and set it up over and over again and have that muscle memory. I will say that I am one of those people that once I mess something up, I will probably never mess it up again. I can kind of remember things that way, but I think just taking the time on your end and doing a little research and just seeing what other kind of videos are out there. I've been really surprised about some of the awesome videos that I've found lately, just doing some research for my own classes. So
nice. So everybody gets SIMV volume with the PEPA 5, right?
Yes, if you are in Facebook world, maybe.
I mean, really, right? Like, we've got to start somewhere, right? So where should people start? I mean, if they don't have this advanced pathophysiology, to understand the disease process, where do people just start? Yeah.
So the best way is, depending on which ventilator you have, I can talk about SIMV, PRVC, all those things, because that's the vent I use so frequently, but there's so many other vents. Some of them are all pressure driven. So what I would tell you is, for me, I'm going to look at start in a volume control mode, whether that's SIMV, PRVC, APRV, whatever you're going to have. And I'm going to shoot for 8 cc's per kilo on every person, pediatric, adults, everybody. I'm going to calculate that out right off the bat and decide that if their lungs were perfect and they were doing what they were supposed to be doing, that this is the kind of volume they should be drawing in. Then I will think about, depending on what kind of process, if it's restrictive or obstructive, how I want to go about that. But I'm always constantly shooting for that 8 cc's per kilo. Even when you have an asthmatic patient and you know that you're probably not going to be hitting that, you want to know where you are if you can calculate that out and say, all right now I'm only exhaling 4 cc's per kilo, but I want to shoot for 8, which is this amount. Then you can kind of see based on all the mag, turb, albuterol, epi, everything you're going to do, you can kind of start watching those exhaled tidal volumes and watching them trend where you want to go. So I would tell everybody, calculate that out right off the bat, 8 cc's per kilo, babies, pediatrics, adults, everybody, and that'll tell you what kind of volume you want to shoot for right off the bat. And if you put them on the vent and it's immediately high pressuring and you have a wide enough alarms that it's not alarming just because it's hitting a PIP of 20. If it's over 35, then you can start decreasing your volume and upping your rate from there. So 2 things we have to look at is our tidal volume and our respiratory rate. So you and I right now, we're looking at a minute ventilation of 4 to 6 liters per minute. Girls are probably a little lower than guys, depending on what's going on. Unless you're pregnant, then you're breathing a little bit faster. But so you're shooting for that tidal volume times respiratory rate equals your minute ventilation. So if you are giving them a tidal volume of 500 and your respiratory rate is 10, then you calculate that out and you'll be able to see where you're normal. Then you have to start thinking about, are they breathing normally? Is this just, did we over sedate them from a seizure and we're just going to ventilate these people because they have no lung disease? Then you have to start thinking about if they have lung disease. Okay, so I want 4 to 6 per minute, but depending on what's going on with them, are they septic? They're going to need a higher minute ventilation probably. So shooting somewhere between 6 and 10 on sicker patients is where I try and be. The sicker they are, the less you want their minute ventilation, if that makes any sense. You want higher minute ventilation, the sicker they are.
The sicker they are, the higher the minute ventilation.
Yeah, the more support they're going to need.
And that's going to fall back on primarily the respiratory rate, because at some point you're going to max out your volume.
Mm-hmm. And if you max out, then you need to start switching modes. If you're in a volume control mode, you need to start thinking about switching to a pressure control mode, which you're going to take a hit with your volume again. So then you're going to circle back around and say, all right, well, is this a ventilation or an oxygenation thing? At some point you can start adding more PEEP as well, which will contribute to the amount of volume in their chest. A lot of people think, well, PEEP is just going to only help with oxygenation, but at some point your PEEP is actually contributing to how that patient is ventilating and how they're stenting open their airways and their carbon dioxide removal and things like that. So a PEEP is going to definitely start contributing to that tidal volume minute ventilation portion pretty soon.
Interesting. So, okay, so you've got that patient, you start off volume ventilating them, your pressure alarms are going off, you realize your tidal volume, your volume, your mLs per kilo body weight is below 6. Now you need to transition. Okay, you've recognized the fact that you cannot volume ventilate them the way you want to without your airway pressures being too high. Of course, we know we need to look at pathology, right? Is this an obstructive airway disease? They have asthma, so on and so forth. But it can be a little tricky making that transition from volume to pressure, right? Because you need to start somewhere in order to make sure that you're giving them a safe volume, a safe pressure. Right. So what's the best way for someone to transition from volume to pressure mode without pressure ventilating them or under pressure ventilating them and de-recruiting?
Yeah. So the more often or not that I see them, you just undershoot. So basically you'll put them on too little pressure when you switch them over. And then you start having SATs fall. You start, if the SATs fall fast enough, then you start having bradycardia issues. So what I tell people is if I'm going to switch someone over and they're failing volume ventilation for me, meaning they're cycling into exhalation too quick, their vent is saying, nope, this is too high a pressures for me to deliver this volume. I'm going to start at least at 30 centimeters of water pressure for my top number. Most of the time you're somewhere around a PEEP of 5 unless you're having an oxygenation problem, but I'm shooting for 30 to 40 because you are popping off somewhere around 50. If you have your alarm set, that's between 40 and 50 is where people normally have their high pressure alarm. So I want to see on that 30 to 40 what kind of exhaled tidal volumes I'm getting. And also to know when you switch from a volume to pressure, you're changing your inspiratory flow pattern. So you may be able to get a decent amount of volume on a pressure of 30 to 40, whereas you weren't able to deliver that volume in a volume control mode. You were popping off at 50 basically only because of the way that breath is being delivered. So when you switch to pressure, you have a decelerating inspiratory flow pattern. So it kind of, the peak is really quickly, and then it kind of drops off. So you don't have that sustained high pressures, but you do have an increased mean airway pressure. So sometimes patients respond a little bit better to that. And babies tend to respond pretty well to that, even though we're kind of switching into volume ventilation with babies all the time. I tell people not to be nervous about pressure ventilating them because they like it as well.
Don't be a baby about babies.
Yeah, don't be a baby.
So is that pretty standard in all pressure ventilation modes? It's a deceleration breath.
Yeah.
Okay, interesting.
And I think you can change some of that in some of the nicer vents. You can go in and change that. You want to make sure that your flow on your vent, if you have a patient that has a really high minute ventilation need that is probably somewhere between 70 to 100 liters per minute, our vent sits somewhere around 60 to 100. So just make sure for some reason that you don't have like a 40 liter per minute flow going on, because then that's not going to be enough to sustain that patient. You're not going to be able to get the inspiratory flows you need.
Gotcha. Interesting. So I know, right, there's a lot of, like when we're talking about ventilating difficult patients, right? Some of the ones that we think about mostly are like your ARDS patients or your asthmatic patients. So what are some strategies that you might be able to share about, let's start with the ARDS patient, because I think we almost see intubated ARDS patients more often than asthma patients. So these ARDS patients, they have really stiff lungs. We have a difficult time oxygenating them. We know that they require high PEEPs in order to oxygenate them, but they also have high pressures. So what are some strategies that you can give to help us kind of work through these patients that can be very difficult to oxygenate?
I think one of the hardest things about ARDS patients is the comorbidities that we have to deal with. So when you have that big cascade going on in that fluid shift, their lungs are starting to fill with fluid. Now, whether that's pulmonary edema or just kind of interstitial edema, kind of on the outer part of the airways, sometimes it's different. But one thing I think that we, as transport caregivers, should get away from is supine transporting. I think that gravity, we're working against ourselves when we lay these patients flat on their back, and we're decreasing the amount of lung that we have to work with. A lot of times that apical part of their lungs is really the only good part right then and there. And when you lay them down, that fluid tends to kind of shift up, and you're taking that whole posterior portion of their lung out of the picture. So I think that the number one thing I think with these patients is positioning. So depending on your transport environment, and I can't wait until I'm the first one to do this here, but obviously prone positioning is the way to ventilate an ARDS patient. I'm waiting. I don't get these kind of patients very often. Sometime I'm going to have one. But I can't wait to transport someone prone. I've seen other agencies do it on the East Coast. I've watched videos of how they talk about flipping them if they go into arrest and things like that. So I think that's kind of the wave of the future, is being able to position these patients differently and being able to move that edema from side to side and get a good lung for a little while, and kind of not book two bad lungs, one good lung, one bad lung based on how they're turned. But I think for us, just sitting them up is going to be a humongous deal to try and recruit some more of their lungs that we've just been kind of drowning, just because it's easy for us to transport them flat on their back.
I want to be there the first time we prone a patient in our aircraft.
Yeah, I can't wait to send a picture to our physician advisor. Look what I just did.
That's going to be awesome. So what I'm hearing you say is we sit the patients upright a little bit, but it sounds like we should be sitting them up even more, right? I mean, maybe even bolt upright as much as possible. As
much as we can. We already anticipate putting pressors on these people. Yeah. So that patient that's borderline, that starts trending down below 100 when you sit them up, I mean, you're going to have to work that fine balance. Are you going to lay them back and just fight with the ventilator the whole time? Or are you going to sit them up and start to gain some ground and change your ABGs a little bit and have to throw on a little bit of whatever vasopressor you love?
Right. Yeah.
I push the vasopressors early. I'm an advocate for it because you already know you're going to need it. You know,
Right.
the body is just constantly constricting and opening, depending on what is going on in that septic process that's going on. So I say just do it early and start messing with their lungs.
Right. Yeah. Because we know we need to recruit that non-stress volume, right? And you know, we start changing them from negative pressure to positive pressure, and we've got to fill that IVC. We've got to give them the preload to keep their blood pressures up. So, yeah, I'm with you on that one. Get the pressors going early. Recruit that non-stress volume. I just took TCAR, trauma care after resuscitation, and it was the first time I heard anybody actually say that. I think it was 70%. I have to go back and look at my notes, but like 70% of your circulating volume is in your venous side. That to me was astonishing, you know, because we know that these septic patients, they vasodilate everything. And so I don't know, for some reason I thought it was more 50-50, but apparently not. We definitely need to recruit more of that venous load.
Yeah, and we see that pretty easily when you start getting those really high peeps and it's impeding all that in venous return, you know, and so that becomes a fine line. That's why I do what I do. I love those type of patients that require all that thinking. You know, it's not just a respiratory process going on. There's so much going on with those patients. I love those patients.
Yeah. Yeah. I mean, I'm thinking about a trauma patient I had recently, probably some significant pulmonary contusion, probably some blood loss, probably pneumo, you know, involved there. But no matter what we did, we just could not get this person to oxygenate. I mean, our peeps were up, our O2 was up. And that was the one thing we just didn't think about doing, was sitting them upright and getting, I mean, we had pressures going, of course, but sitting them upright to try and recruit more of that lung volume to improve his oxygenation.
Yeah. And, you know, trialing back and forth between a volume mode and a pressure mode, just to see where their lungs are and what they'll kind of tolerate, you know, and if you're getting somewhere with pressure, just not where you want to go, taking that next step kind of down that rabbit hole is that inverse ratio ventilation. And when you're there and the patient starts responding to that, you know, you're headed towards like prone ventilation, high frequency ventilation, and maybe even ECMO if that's what that patient likes.
Yeah. You know, I can't tell you the last time I saw anybody try IDE or inverse IDE. Can you talk a little bit about that? Because I don't think it's anything that we see that often. And with the exception of like your asthmatic patients where you're really prolonging their exhalation phase, I don't think it's something that we tend to think about when we're trying.
And I kind of think in my head, to me, it's almost like a guideline, you know, like when you're looking at that NRP guideline and there's this step, this step, this step, you know, so if you failed volume ventilation and then now you're on pressure control ventilation and your stats are still bad and all these things are happening, for me, I think this is where a lot of people are going to ditch it and bag the patient. For me, this is where I want to try the inverse ratio ventilation. And I feel like I don't see it a whole lot in the transport environment, and I don't know if it is a respiratory thing or if there's just so many new modes on different ventilators. I guess it kind of depends on what vent you have. But I think if you have a volume ventilator like we do, I think that's that last step. That's almost the last thing we have to offer them before we get to a hospital, because we can't prone them in flight, obviously. That would have to be something done early on. And if they're sitting up and doing all those things, then for me, that's my last ditch effort. And I think almost like, you know, we automatically think with asthmatics, yeah, we need to prolong their exhalation time. I almost think with these ARDS patients, we should early on be thinking they're going to need a longer inspiratory time, where you're trying to push that volume past, you know, a fluid-filled, septic-filled system that's already high pressure. You're going to have to push even harder. So instead of trying to slam all that volume in at a really quick I time and giving them a longer E time, why don't we try and keep that volume going in the same volume, but over a longer period of time? That transcends into a higher mean airway pressure, which we know will give us better oxygenation. So you'll help clear their CO2. You're going to help with their oxygenation. I almost think it should be, that's what we should be thinking with our type of vent in an ARDS patient early on. especially if we're going to pressure ventilation. You're not going to, I don't think the difference in that scenario with an ARDS patient, I don't think just switching them to pressure is what's going to fix them. I think anything we can do to increase their mean airway pressures, and the only way for us to do it is an inverse ratio, really.
Okay. And well, what about, I mean, I guess what we're talking about here is playing with those I times, right? So what you're essentially doing is you're manipulating the respiratory rate and their I time in order to give them that inverse IDE ratio.
Right. So I just kind of start, normal with adults is a 1 I time. So right. That's going to put you somewhere between 1 to 2 to 1 to 3 IDE ratio. So I just kind of start widening that out. I'll go to like 1.5 and see how they do, give them, 2-3 minutes. And then I'll just kind of start inching it up from there. Unless I walk in and they're on pressure ventilation and they're just failing, then I might automatically switch it to like a 2 to 1 or a 3 to 1.
Okay, so assuming that this patient has already kind of transitioned from volume into pressure and they're still failing.
Yeah.
Gotcha.
Yeah, and if you don't see the jump you need from volume to pressure within 3 to 5 minutes, there's not too much tweaking with pressure control that we can do at that point. If they just don't like it and they're not returning volumes, number one, we do need to start thinking about that inverse ratio, but then we need to start thinking about, do we need to add some bronchodilators? Is there, an anaphylactic component to this? Like, what else can we do to help roundabout hit those respiratory receptors, not just through the ET tube, but peripherally?
Right. And right, because we know that like once we put the tube in, that's not the end all be all, right? We still have to continue to manage these patients and use that ventilator to facilitate the delivery of these medications to try and turn them around. Mm-hmm. Yeah. I mean, I think it's all really good points. I just want to kind of take a minute here and reach out to the crew that's listening in. Chris, and Matt, do you guys have any questions that you want to ask Melissa? And I can kind of turn on your mic, if you will, and give you guys a chance to ask her any questions. Let's see. I'll pull up the chat here and see if there's anything else from people out there in Facebook land. Who else? Chris, was that you? Or is that you, Melissa?
I think it's me messing around.
Oh, yeah? Let's see. Matt. Go ahead, Matt. Go ahead. I'll let you ask your question. Let's see here. Let's see if I can unmute. Matt says, how often do you use PRVC in the transport field? Go ahead, Matt.
Can you hear me okay? I don't know how well this mic is working.
Yeah, no, we got you just fine.
Perfect. The first time we've used the mic on this laptop. No, I use PVRC a lot in the transport environment that I work in. How often do you guys?
So for us, PRVC is kind of our starting point for every patient. I will tell you that just from my experience, I'm noticing that the kids do not like PRVC. And I think it just has to do with they don't like the varying pressures in their chest from breath to breath. I think a lot of our adult patients are fine with that, but I think our kids are just not being as responsive to that. So I think straight up volume control, like SIMV for our kids, have been better. Or if you're just going to pressure ventilate like our little itty bitty kids, that's fine. But as far as PRVC goes, the only time we start deviating from that is if we start having some difficult ventilation issues. We want to kind of control everything and know that that pressure is consistent every single breath. So that's when I would say to kind of switch off of that if you want to have ultimate control over that patient. And if you're going to paralyze them and stuff like that, PRVC really doesn't need to be there at that point. But if you have a patient that is contributing to their ventilation and being helpful with it, then definitely PRVC is a good starting point. And it's definitely where we always start on our patient and kind of go up or down from there.
Thank you.
Cool. Good question. Thank you. I've got another question here from Chris. Chris, let me spool you up here and then I'll let you ask your question. Yeah, it might take just a second for it to unmute. Go ahead, Chris, with your question.
All right. Can you hear me?
Yeah, we got you.
Okay, so like I typed in, our average flights are like 25 minutes. So we can't make too many adjustments on a vent. Don't want to be constantly touching things and chasing our tails. So what would you say is a good average time period to wait after making a vent change to realize that it's not going to improve, or what your improvement time should be? A couple minutes, 5 minutes, that you should be seeing a change if you adjust something?
Ideally, I would say 5 minutes, but that can feel like an eternity when things are not going your way. One thing I like to do is, before I leave, have them pull a ABG so I at least know where I'm starting from. I don't like to take one that's a couple hours old. So a lot of times when I'll walk right in, normally, and even in our rural hospitals, we're greeted with a nurse and an RT, and then a physician is somewhere in that mix. A lot of times I'll look right over at the RT and just say, "Hey, can you draw me a new gas? I have my iStat right here." If they have an art line, even better, but we're not transporting too many of those lately, unfortunately. I would say at least 3 minutes to watch it happen on the vent and watch your end tidal. I would say don't make humongous changes off your end tidal unless you have a gas to correlate with it. We're seeing a lot of times with those big VQ mismatches that our end tidals are 10 to 20 off, which is okay as long as you know, and you're not making vital vent changes just based on that end tidal if you don't have a correlating ABG. But 5 minutes is ideal, really. 3 if things are really dire situation. I try not to make more than 2 or 3 on our trips, and our trips are about 30 to 40 minutes. 2 or 3 vent changes. However, I try and space that out. Depending on, as long as their heart rate and things like that can tolerate it. But I'm kind of with you that I try and only do 2 or 3 changes during a trip. Just because depending on if I can access another ABG or not, I don't want to show up and have just pushed them off the cliff with all my aggressive settings. So I would say 5 minutes if their status can tolerate it.
Cool. Do you have anything else? Any follow up there, Chris?
Nope, I'm good.
Excellent. Well, thank you for the question. I think that's a really good one, because I think it's easy for us, right, to make a change and realize we're not getting the result we want, and then make another change. Mm-hmm. Now something starts to happen, and we realize, what just worked.
Yeah, and you may be getting a change arterially with your A to A gradient, but you may not see that on your end tidal. That end tidal may take a lot longer to catch up than what is actually going on in their body. So just solely relying on the end tidal is not something I like to do. Right.
I guess one last question, and then we'll start to wrap this up. ABGs versus VBGs, right? It's great to get ABGs in the aircraft, and we try, and we, of course, if you can get it before you leave. But what is your feeling about using a VBG and using that to titrate your vent settings during transport?
I'm totally fine with VBGs. When I started, you draw a lot of cap gases on babies. So as long as you know the different values and you're not trying to overcorrect for those type of scenarios, just knowing that, your CO2 is going to be off a little bit, and obviously your oxygen is going to be off a lot. Just if you're comfortable with those values and you're not trying to overcorrect them to an arterial value, I think is totally fine. I'm fine with VBGs.
Right.
I think it's great to be able to brag that you got an ABG in the aircraft, but honestly, I rarely can even get them in there. So it's been a like on one hand in 7 years, the amount of times I've gotten one in flight. So without an A line. So.
Right. And you talked about trending your end tidal CO2 based on your or knowing how they trend together, because I know how we do that when we work. But do you want to elaborate on that for people who may not fully understand what exactly you mean by not titrating your vent based on your end tidal CO2?
Yeah. So I think that especially in the EMS world and as paramedics, we get that end title and the need for it driven into us, which is a great tool.
Right, 35 to 45, right?
Yeah, if that truly is what it is. So the problem is that a lot of times, depending on if you have a lot of fluid in your body, if you have a different process going on, we know our DKA patients have a big old metabolic process going on. So those end titles are going to be off for those type of patients. I think they're very reliable in our cardiac arrest and our ROSC scenarios because they're so low. And we're just looking to hit that like 20 to be able to start resuscitating again. Where I think we fall into problems is with our COPD patients, because we're allowing those patients to hang out like 60 to 75. So depending on if your end tidal is above or below, if you don't know, you're kind of guessing in the dark. If your end tidal says 75, but it's actually their arterial oxygen content is 95, and you leave it there, the longer they're in an acidotic state, the less they're going to be able to absorb oxygen. So we're just increasing an anoxic injury that's already forming. So I think knowing early on and being in a range and not just being, okay, I'm going to get this to 35 and I'm going to leave it. Have a pretty wide range, I think. If you're shooting for 35 to 45 and you're at 55, I don't think that you messing with the ventilator anymore is going to help them out until we can correlate with a gas, for sure. So,
or treat your patient if the meds that you're giving them are working, then you can assume that their pH is at least within a somewhat physiologic normal range, at least not so far out of whack that they're not going to be, their liver function's not working, the medications aren't going to be working.
Right.
Awesome. This was fun.
It was different. I liked it.
Yeah. Hopefully we can have you back again to talk a little bit more. I want to say thank you. We're getting close to that 1 hour mark, so I'm going to wrap this up. This was awesome. I thought this was super cool, and I'm going to be sharing this out again. If people want to find out more about you, where can they go?
So I created a education program called Beyond the BVM. Right now, my only social media is on Facebook. So if you go to Facebook and look up Beyond the BVM, that's where I'm posting a lot of my upcoming classes. And then on Friday, I'm doing my first 8-hour ventilator seminar for EMS only.
Yay! And I'll be there. Super excited.
Yeah.
Yeah. So if you guys want to find out more, of course, Facebook, Beyond the BVM. And I have a link to Melissa's class in the group, which I will post again. So you can check out the group in FlightCrit, or I'm sure that she's got a link over on her group as well. We'll do some cross posting, really get the word out there. If you like this, send Melissa a message, tell her to come back on the show, and we'll do some more stuff again. And I want to say thank you. This was super cool.
Yeah, thank you so much for inviting me.
You're very welcome. We'll do it again. Thanks, everybody. If you have questions that you want to send to Melissa, go ahead. You can leave them in the comments section, and I will get them over to her. Okay? Thanks, Melissa.
Thank you, guys.